operative obstetrics. Operative obstetrics means which operations are usually done in the field of obstetrics or during the time of delivery or labor. So this topic is all about that. Now see here, look at the definition. Any method which is used to deliver the fetus other than uterine contraction and maternal pushing effort, okay, comes under operative obstetrics. Any method used to deliver the fetus other than uterine contraction and maternal pushing effort comes under operative obstetrics. Now you can clearly answer here even before we go to the further slides. Which are those ways to deliver the baby apart from the normal way? Which are those? Yes?
C-section.
C-section, forceps,
by resection pumps are mainly.
Exactly. Okay, all the answers I already got here. One is cesarean section or C-section. Another is a forceps delivery, and another is a vacuum delivery. So these are the three ways: cesarean section, forceps delivery, and vacuum delivery. So these are the different things we discuss under operative obstetrics. Now see here, forceps, vacuum, and cesarean. So forceps delivery, vacuum, also known as ventouse extraction or vacuum extractor, and cesarean section. So we are going to talk about them one after other in this class. Look at this picture here. The three things are shown in this slide. Okay, one is forceps. You can clearly see these are the blades of the forceps. This is vacuum, okay, or ventouse. This is a suction cup. This is one part of the vacuum, and this is the knife which is used for cesarean section delivery. So these are the three important, mechanism or way of the obstetrics delivery. Now, let's start with obstetrics forceps. These forceps are the metal instrument which are used to provide traction, rotation, or both to the fetal head. These are, used for the delivery of the head only. Either in case of cephalic presentation or in case of breech presentation also. After the whole body is delivered, only the head gets stuck sometime, So for the delivery of that head also, a forceps can be used. So once again, forceps are the metal instrument which are used to provide traction, rotation, or both to the fetal head. There are different types of obstetric forceps available. They are called Simpson forceps, Keyland forceps, Piper forceps, and Barton forceps. Now, Simpson is used for the traction only in occipito-anterior type of position, not in other type. OA means occipito-anterior. Keyland is used for head rotation and traction. Piper is used for the aftercoming head of a vaginal breech baby. That's what I talked just now. It is also used in the breech delivery, but not for the delivery of the buttock, or for the body, only for the aftercoming head delivery. And Barton is used to deliver the head even in occiput transverse position with a platyploid pelvis. Now, you may be wondering what's the meaning of this platyploid pelvis. Now, a little bit of information here. The maternal pelvis is of different type. The most common type of maternal pelvis is called gynecoid pelvis, also known as female type of pelvis. Of course, this is the most common one. There is no problem for the delivery of the baby through gynecoid pelvis. The second is called android pelvis. It's a male type of pelvis where the ischial spine are quite closer to each other, or in other words, the diameter of that pelvic cavity is smaller. Okay, some tall lady or tall female are having android type of pelvis. And the third one is called platyploid pelvis. In this type, the pelvic brim means the inlet of the pelvis, is kidney shaped and the cavity is shallow than the gynecoid one. So there is a problem in the delivery of the baby. So we can use Barton forceps to pull the head out. Now look at this picture, okay, which will tell us everything how the forceps delivery is done. See this? These are the blades of the forceps. As you can see here. Let me use the pointer. This is called blade of the forceps, okay, and this is the handle, right? The blades are locked here, and they are, attached to the presenting part of the baby. And we give a bit of traction force on this area so that the whole baby is pulled outside. This is known as a forceps delivery. Now see here. So these are the different parts of the forceps, okay? Different parts of the forceps. This is a Killian forceps, and the characteristic features of the Killian forceps are the minimal pelvic curvature, sliding lock, and the lightweight. So here's the sliding lock, you can clearly see. And this is the pelvic curvature of the forceps. Now, let's classify the different types of obstetrical forceps. What are the different types are there? One is known as outlet forceps, okay? Another is low forceps, mid forceps, and high forceps delivery. Now, what do you mean by outlet forceps delivery? This, in this type, the fetal head is already on the pelvic floor, okay? It is already on the pelvic floor, and most forceps use is in this category. This is the outlet forceps application. You can understand like that. And now, one question should come in your mind. If the fetal head is already on the pelvic floor, then still, why it is not delivered? Why the fetal head is not coming out? And the answer, the most obvious answer here is the mother probably is too tired to push. Okay, she is completely fatigued. There is no more power left in her. So remember, without maternal pushing effort, the baby would not come out. Only the uterine contraction is not enough for the delivery of the baby. So during this time, we use outlet type of forceps to pull the head out. Okay, this will make it easier to understand. Low forceps means fetal head is below +2 station, but has not reached the pelvic floor. So it is, above the pelvic floor, but it is definitely below the ischial spine. That's what we call it +2 station, isn't it? At the level of ischial spine, we call it 0 station. Below, we use the +1, +2, +3, +4, +5 like that. So in this situation, the fetal head is below +2, but has not reached the pelvic floor. So we use low type of forceps delivery. Mid forceps delivery means fetal head is below the 0 station, but has not reached +2 station. And it is seldom used these days, okay, not commonly done. And the high forceps delivery, fetal head is unengaged. That means above the 0 station. That means above the ischial spine. And this is never appropriate in modern obstetrics because of the risk to both mother and fetus. It is highly dangerous. Who knows what is the pelvic capacity there? How wide is the pelvis? Until and unless you make sure about this, don't even try for the high forceps delivery. So if there is no engagement of the head, the safer option would be cesarean section rather than a forceps or vacuum type of delivery. Now, another important part of this obstetric forceps lecture, what are the indications of forceps application? Okay, indication. In which situation we apply the forceps? See this, please. What is prolonged second stage of labor? Okay, prolonged second stage of labor. This prolonged second stage of labor may occur because of dysfunctional lever or suboptimal fetal head orientation. This is the most common indication for forceps. Dysfunctional labor, either the uterine contraction is poor or maternal effort is poor. A suboptimal fetal head orientation means, the proper rotation or the descent of the fetal head has not occurred. As a result of this, second stage of the labor is prolonged, and if it further gets prolonged, it will lead to fatigability of the mother. This is a very difficult process, this labor and delivery. Okay, so huge amount of effort is there on the mother's body. So just to avoid this, we can go for forceps delivery. Second indication would be non-reassuring electronic fetal monitor strip. What do you mean by that? That means the fetal distress is almost there. There may be some irregularity in the fetal heart rate. Either it is going up or coming down. Okay, the fetus is not tolerating the labor process. In this situation, we need to take the baby as fast as possible, and one of the ways is forceps. Third important indication, to avoid maternal pushing. Okay, to avoid maternal pushing. Now you may be wondering, just now I told you maternal pushing is very, very necessary for the delivery of the baby. But right now we are saying, what are those situations when maternal pushing should be avoided? Remember, heart disease in the mother. Heart disease. What if she is a patient of congestive cardiac failure? Okay, so during that time, too much effort or too much pushing is not good for the mother's health. So to avoid the maternal pushing, okay, we should apply the forceps or the vacuum in the baby, and it should be pulled quickly. Okay. Similarly, some pulmonary or even neurological disorders, we should go for the forceps delivery. And then breech presentation. To shorten the time to deliver the head of a vaginal breech fetus, we can go for obstetrical forceps. Remember, once again, you don't put forceps on the buttock area of the fetus. You allow the buttocks to be delivered. You allow the body to be delivered. Only the head will get stuck sometimes, and to deliver that head of the vaginal breech fetus, we can apply forceps. Let's move on. Now, what are the prerequisites of obstetric forceps delivery? Prerequisites means what we need there. Okay, what points needs to be fulfilled before we apply forceps? These are called prerequisite. Clinically adequate pelvic dimension must be there. Now, in the last few classes, okay, we talked about this. This is about the pelvic diameter. There are three important parts of the pelvis of the mother. It's called pelvic inlet, pelvic cavity, and the pelvic outlet. To judge whether this is enough diameter or not, okay, the obstetrician would examine before the delivery. One of them is called diagonal conjugate. Another is called transischial diameter, okay, between the ischial spines, also known as interspinous diameter. And another is diameter between the tuberosities, isn't it? Ischial tuberosity. So see there, these are the three terms I'm using again and again. To know the pelvic inlet, you go for diagonal conjugate. To know what is the diameter of the maternal pelvic cavity, you go for interspinous diameter. And to know what is the diameter of the pelvic outlet, you go for diameter between the ischial tuberosity. So all of these diameters should be adequate for the application of obstetric forceps. This is the meaning. Another prerequisite, there should not be any obstruction. There should not be any obstruction. And the obstruction can occur because of these things. If the bladder is not empty, if there is a contracted pelvis, if there is a presence of ovarian cyst, and if there is, pelvic kidney, then there is a chance of obstruction. So all of these things should not be there. Okay, there should not be any cyst present in the ovary. There should not be any pelvic kidney. Pelvic kidney is a, what do you mean by pelvic kidney, by the way? Where is our kidneys present normally? Where?
Lumbar region. Lumbar T12 to L3 vertebra.
Exactly. You can say lumbar region.
It's in the pelvis instead of the abdomen.
Exactly. So normally,
this is pelvic kidney.
Exactly. Normally the kidneys are present in the lumbar area. Every student know that. But in this situation or in this condition, the pelvis or the kidney is present in the pelvic area. This is one of the congenital anomaly of the kidney location. And sometimes what happens after the kidney is transplanted, okay, the kidney transplantation is done in some of the people, and then that kidney is also present in the pelvic area. So these are the two important conditions. Third important prerequisite is experienced operator. This forceps delivery is a complicated type of delivery. So a good experienced person only should apply the forceps, not other person. Otherwise there is a high chance of complication. Fourth important prerequisite, the cervix should be dilated fully. Full cervical dilation must be there. Another, engaged fetal head. Without engagement, you cannot apply forceps. If you try, there is a high chance of complication. Another, orientation of the fetal head should be certain. Okay, like in case of occipital anterior, it is the best for the application of the forceps. Sometimes even in occipital transverse position, they can apply the forceps, but it is not commonly done. So in OA and OT, OA is occipital anterior, OT is occipital transverse. Okay, the head, the fetal head should be at least in 0 station, 0 at the level of cell spine, not above that. In occipital posterior, it should be at least 1, okay, 1 centimeter below the cell spine level, and there should be a proper analgesia and anesthesia use. Proper analgesia. Actually, analgesia would be enough rather than anesthesia. Okay, so these are the important prerequisites. Now look at this picture here. There are different types of forceps. One of the type is called Wrigley's forceps, and this exactly how it looks. So these are again the blade of the forceps, and this is the locking area, and this is the handle. Okay, and these are the two important two parts of the blade. What's the use of this Wrigley's forceps, and what are some of the important points? Let's go through it. It is obstetric forceps for outlet forceps delivery. Okay, outlet forceps delivery means when the presenting part is touching the pelvic muscle or the pelvic floor, then we use Wrigley's forceps to deliver the baby. That's the meaning. It has got a good pelvic curve, and the parts of this forceps are blade, okay, shank, lock, and the handle. So the different parts. You can clearly see that in the picture. This blade has got windows or fenestration for the firm grip of the fetal head. Okay, so what does that mean? Look at this. Okay, so this fenestration, also known as window, is present for the firm grip of the fetal head. So this is Wrigley's forceps. Another forceps can also be used like Simpson short forceps. This Simpson short forceps is a straight forceps with only cephalic curve and no pelvic curve there. But it can be used. It depends what is the choice of that obstetrician. Some of the prerequisites for Wrigley's forceps use are dilatation of the cervix must be full, that is 10 centimeter, and station of the vertex should be at +2 or +3, because we are talking about the outlet forceps, also known as Wrigley's forceps. So the station of the presenting part, okay, the most common presenting part is the cephalic or the vertex, so it should be at least +2 or +3. So let me ask once again, though I have told this point so many times till now, because many students probably they don't listen properly when we are taking this type of classes. So what do you mean by +2 or +3 station? What do you mean by that once again?
Sir, it means that it is below the ischial spine, sir.
The head is
The head is below the ischial spine.
2 or 3 centimeters below this spine.
Excellent. Very good. Okay, never forget this. Ischial spine means 0. So below than that, we use the term +1, +2, +3, +4, +5. About a centimeter difference. +1, 1 centimeter. +2, 2 centimeter, like that. Okay, that's the meaning. Very nice. Now, what complication can happen because of the forceps delivery? Why it is considered a complicated? Why we need a lot of experienced, to conduct this type of delivery? See here. These are the maternal complications of forceps delivery. They are laceration to the vagina, cervix, perineum, and even the uterus. Because of that big blade which should be applied there on the presenting part. And if we pull a bit powerfully or forcefully, okay, there would be a lot of laceration formation. Regarding the fetal or neonatal complication, there may be soft tissue compression or cranial injury caused by incorrectly placed forceps blade. This is again by the inexperienced person. They may compress the presenting part. Okay, they may damage facial nerve sometimes. Sometimes, they may damage other soft tissue there. So all these things can happen because of forceps delivery. Now, see this picture here. All of you please focus on your screen. This is the picture of a baby, okay, who has suffered from forceps injury. Look at this area, especially this area. This is the soft tissue injury, which is caused by the application of the forceps. Now, have a look here. What can you see in this baby? Can anybody explain to me what's going on in this baby?
Facial nerve palsy.
Facial nerve
Facial nerve palsy.
on the right side.
Excellent. This baby is suffering from facial nerve palsy. Wonderful. Okay. Very impressive answer. But every student should know which side is affected here. Which side?
Right side.
Right side.
Right side.
Okay, let me ask you the direct question. Is the side where the eye is opened is affected, or is the side where eye is closed is affected?
Open.
Where the eye open,
Where the eye is open, sir.
Where the eye is open. There the nerve is on the cross. There's that cross nerve.
There is like
Okay.
fixation of nerves. That's why.
It is fixation of nerve fiber, exactly, sir.
Okay, now see there, you're absolutely correct. When facial nerve is paralyzed, okay, this is a lower motor neuron type of paralysis, definitely. So the one whole side of the face is gone. The baby cannot close the eye. The baby cannot close the eye. So definitely this side is paralyzed. Yeah, this is paralyzed. Not this. Yeah, see there, eye can be closed nicely. One more point. Look at this angle of the mouth. The angle of the mouth is pulled towards the normal side, and there is a formation of nasolabial fold there. This is called nasolabial fold. If this fold is formed, okay, then we know that side is normal. It is not paralyzed. Whereas the other side, angle of the mouth is slightly drooped. See this is slightly pulled upward. It is slightly drooping. Okay, so this side is definitely paralyzed. Very good answer. This is another complication of forceps delivery. Probably the facial nerve is damaged here. Now, have a look here. Okay, the same baby on the right side, but on the left side, Probably the baby has recovered later on. But why the baby has recovered? Probably, okay, the answer, yes, please.
Sir, because there is a at that time there is not proper myelination of nerves and there is not a proper development of the nerve. That's why after developing the nerve, baby again recover.
Now, that's a good answer you have given, okay? So that's a bit of a difficult question actually at this stage because we have not taught about the different types of nerve injury to you. There are 3 types of nerve injury. The most, milder type of nerve injury is known as neuropraxia. So let me, give a little bit information here for you. See this? Let me write it here. Neuropraxia, okay, is the most milder type of nerve injury. After that, axonotomesis, okay, axonotomesis, and then neurotomesis. These are the 3 types of nerve damage or injury: neuropraxia, axonotomesis, and neurotomesis. Neuropraxia is only the compression of the nerve, okay, only the compression of the nerve. There's not a serious type of injury, so within few days there is regeneration, or the nerve can come back to the normal function. Axonotomesis is a damage to some of the axon, but still the outermost covering of that nerve, it's called neurilemmal sheath, is still intact. So this can also recover in time, whereas neurotomesis is a complete division of the nerve. It's a complete cut of the nerve into 2 pieces. So without any surgical treatment, this nerve cannot regenerate back. But if we join this nerve quickly after the injury, then this nerve can also come back to the normal function. So probably in this case, this is a neuropraxia type of injury. So the baby has recovered on its own. Okay, so let's move on. See here. Look at this picture. This is another picture of forceps injury to the newborn baby. So behind the ear, there is a bad type of injury which is caused by the forceps. After we talked about forceps delivery, let's enter into the second part of this obstetrics, operative obstetrics, which is a vacuum or ventouse extractor, or vacuum delivery, you can say. So what is the definition of this vacuum now? These are cup-like instruments that are held against the fetal head with suction. So the head is pulled outside with the help of suction force here. Traction is thus applied to the fetal scalp, which along with maternal pushing effort results in descent of the head, leading to vaginal delivery. This is called vacuum extraction. So what is the meaning? You apply the cup of the vacuum on the presenting part and you give constant traction. Along with that, the mother should push. There should be a pushing effort from the mother side and the baby would come out. The cup of the vacuum may be metal, may be plastic, it may be rigid, or may be softer. There are different types of vacuum available. Now look at the structure of this vacuum here. This is the cup. This is the cup of the vacuum, and here the person who is conducting or assisting the delivery will catch and then give a constant pull. And the mother should give a pushing effort as well. Remember the one of the movie, okay, which is a very popular movie, isn't it? I'm 100% sure all the students have seen that movie before. 3 Idiots, isn't it?
Yes, sir.
Yes, sir.
In 3 Idiots.
Yes, sir.
In 3 Idiots, the main actor, he delivered the baby with the help of this vacuum. He created that vacuum there, isn't it? He's a genius person. He's an engineer actually, but that's how the baby was delivered. They have utilized that principle in the delivery of the baby. the same principle is applicable in the delivery room also. The facilities are a bit, higher there. There's some advanced, technologies are there, of course, but the principle is still the same. Now see this. This is a, vacuum cup, which is nicely fit on the presenting part, and then a constant pull is given. We ask the mother to push, then the baby can be delivered. So this is a very good schematic diagram, which is showing the vacuum extraction. Look at this. The vacuum is applicable on the presenting part, okay? And then it is pulled outwards. These are the different parts of the vacuum. This is a cup. This is a metallic cup. This is probably the plastic one, okay? And this is the silicon rubber cup here, okay? And this is probably the similar type of material, silicon or plastic. Now another picture is showing us the vacuum extraction. Look at the examiner is catching at the handle, and the vacuum is nicely fitted on the presenting part, and the head is almost delivered outside. Now, what are the advantages of vacuum over forceps? Why vacuum is more popular than forceps delivery all over the world? There has to be some advantages of vacuum over the forceps. That's why it is popular, isn't it? The first thing is fetal head orientation. The precise knowledge of fetal head position and attitude is not essential in case of vacuum delivery. That is a huge advantage. We just need the presenting part as the fetal head. We don't worry about whether it is occipito anterior, occipito posterior, or something like that. The vacuum extractor doesn't occupy the space adjacent to the fetal head. It doesn't. So there is a less chance of injury in those areas. Third and fourth degree lacerations are very rare in case of vacuum delivery. Okay, in forceps delivery, the chances are more. And regarding the head rotation, the fetal head rotation occurs spontaneously at the station which is best suited to fetal head configuration and maternal pelvis related to the vacuum delivery. So the rotation occurs spontaneously when we apply the vacuum. We don't need to, manually rotate the head or doing other type of things. So these are the advantages. And let me tell you one thing. I have also delivered a lot of babies by a vacuum application when I was working as a medical officer after doing the MBBS. Okay, before I went for my master degree, I worked for a few years in one of the hospital, and we used to conduct all different type of things there. Sometimes delivery, sometimes surgery, isn't it? Sometimes other type of things. So this vacuum delivery is not a very complicated one, but we must make sure the vacuum is nicely applied on the presenting part.
What are those? One of the common disadvantages is the vacuum is easily popping out or popping off. What does that mean? It is released. It is getting released easily from the head of the baby. Even without a good pressure, or even without dragging the baby out, the vacuum itself is popping off. Now remember one thing, this is a very important practical information. You can only apply vacuum cup for 3 times, not more than that. So when an experienced person is needed there who can pull that baby with 1 or 2 application of the vacuum, maximum 3, but not more than that, because there are some complications associated with repeated application of the vacuum cup. Why? Okay, the question is why? Because suction force is necessary for the delivery of the baby. That suction force may damage the presenting part. That is the meaning. Second one, see here, is the scalp trauma. So because of that excessive suction force, or the vacuum force, you can say, scalp skin injury and laceration can occur, but they are not very common. It can occur in haphazard type of application. If the person is not experienced at all, that person has never done vacuum delivery before, That can happen. Another one is subgaleal hemorrhage and intracranial bleeding. They can occur, but they are very rare. Now, what is this? What is the meaning of this term gallia? Anybody? What is gallia? Yes, who can answer this?
Rupture of emissary vein.
Sir, it is the subgaleal hemorrhage. Sir, it is the rupture of the emissary vein. Sir, it is the connection between the between the dural sinuses and sir between the veins of the scalp. So this area might be the gallia, sir, and here the rupture occurs.
Okay, now listen. Okay, probably you know you have not. Yes, yes. Somebody is saying something. Yes, please.
Blood accumulates outside the body of the baby skull.
Okay. Now listen here. Okay, probably the anatomy of this particular area was not taught properly before. We are talking about the scalp area. Scalp means it's the covering of the skull. Scalp, that's a thick skin, you know, that is called scalp. It has got 5 layers. It has got 5 layers. The outermost layer is skin, of course. Then we call it subcutaneous tissue. Okay. The third layer is known as gallia aponeurotica. So this is a type of aponeurosis. Okay. It is a type of aponeurosis. And we know aponeurosis is a flat tendon. It's a type of tendon which is flat in appearance. So if bleeding occurs below this gallia aponeurotica, we call it subgaleal hemorrhage. It's one of the layer of the scalp. The fourth is a loose connective tissue, and fifth is called, okay, the pericranium. It's a periosteum of the cranial bone. So let me quickly, you know, say that again, because you want to know this important, you know, anatomical knowledge. The outermost covering of the scalp is called skin. Below that, subcutaneous tissue. Third, gallia. We can simply call it gallia or gallia aponeurotica. Fourth, loose connective tissue or loose areolar tissue, you can say. And the last one is a pericranium. Okay. Neonatal jaundice can arise from scalp bleeding. Now, everybody know that this bleeding is a collection of blood. Okay, there are lots of RBC there. If those RBC disintegrate, there is a synthesis of bilirubin, and bilirubin synthesis can give rise to jaundice. So don't be surprised if that neonate after birth develops a bit of jaundice, and there is something known as physiological jaundice, which is seen in almost 2/3 of the normal babies. And on top of that, because of this excessive scalp bleeding, jaundice can become a little bit more than the physiological one. Okay, so all of these things can happen. Let's move on. Now, what are the indications of vacuum delivery? In which situation we go for vacuum delivery, also known as ventouse extractor or vacuum extractor. Okay, ventouse and vacuum are the synonymous term. Now they are absolutely similar to the forceps delivery indications. If there is a prolonged second stage of the labor, okay, if there is non-reassuring electronic fetal monitor strip, and if we want to avoid the mother to push, if we want the mother do not, you know, strain excessively, we have to take help of vacuum or forceps delivery. Right now we are talking about vacuum delivery, so let's focus on vacuum. So see there, in prolonged second stage of the labor, the lady may be excessively tired. She may not be able to push. Okay, the uterus can also develop atonia if there is a prolonged contraction. So vacuum delivery is indicated. In non-reassuring electronic fetal monitor strip means fetus is not tolerating labor. There may be features of fetal distress. Either fetal heart rate is increased than 180 per minute or decrease than 100 per minute. Okay, so we need to quickly take the baby out. What is the way? Vacuum, forceps, or cesarean section. So vacuum is one of them. Avoidance of maternal pushing. Think about certain situation like heart failure. Okay, like asthma, okay, bronchial asthma in that lady, some of the neurological disorder, some raise ICP or something like that. And if the lady is in second stage of the labor, we don't want that lady to, unduly pushing, or we want that lady to give a little bit, rest, understand, like that. So these instrumental delivery are done during that time. Now, what are the prerequisite? Prerequisite means what are the necessary thing before you apply vacuum? These are important, If we do not meet these prerequisite, then there is a chance of complication either to the baby or to the mother. First is there should be enough pelvic dimension, means the pelvic cavity, okay, should be adequate. The diagonal conjugate should be, adequate. The interspinous diameter should be adequate, okay, and the diameter between the ischial tuberosity should be adequate. That is the meaning. There should be experienced operator. The person should have done many vacuum delivery before, or if the person is quite inexperienced, one experienced person should be there to help him or her, okay. Nobody is experienced from the beginning, remember that. So you should show that interest, but somebody should be there to guide you. That's my point. Third one, cervix should be fully dilated. Every student know by now that is 10 centimeter. Fetus or fetal head should be engaged. We all know what is the meaning of engagement at this time. So it should be engaged. If it is not engaged, then where you apply the vacuum, isn't it? It is way high up. We cannot apply. And gestational age is 34 weeks or more. Okay, this is another prerequisite. Vacuum delivery is not applicable to the very preterm babies. There is a high chance of complication. Now, I'm keep on talking about there is high chance of complication, but what are those complications? So let me clarify them now. So see here, please. The complication can be divided into two: maternal and neonatal, or fetal, you can say. So maternal complications are vaginal laceration. But how does that happen? See there, if the person is not experienced, this type of problem can happen. The person has, included a part of vaginal mucosa between the suction cup and the fetal head. This is a disastrous, type of problem, because that, entrapped piece of mucosa will be lacerated because of the force, okay, of that suction, or because of the power of that suction. That is a very, very, important type of complication. Experienced person will never do that. Another one is neonatal. So what type of problem a neonate can have? See here. Actually, we already talked about that. Cephal hematoma. Now, this cephal hematoma is the collection of blood, okay, the collection of blood in the baby's head. But which area? This is important point to understand. Now, let me clarify this, because this is an important point, though we will talk about this in pediatrics. But once the term comes, you should always want to learn what's the meaning of that term. That is quite important in medicine. That's the way you learn. Don't keep like, oh, we will study it later. No, not like that. At least meaning is important. Now, cephal hematoma occurs in between, okay, in between the pericranium and skull bone. Now, see there. So if a bleeding occurs in this specific area, because of the attachment of the suture, the blood cannot go to the other side. Means it is a, localized type of bleeding there. It cannot cross the suture line. This is a very important point regarding cephal hematoma. And because of the cephal hematoma, the neonate can develop jaundice because there is a collection of RBC there. Okay. Whereas, subgaleal hematoma is a bit of similar type of condition, but it occurs in a different plane. I already talked about this. This is below the gallia aponeurotica, and cephalohematoma occurs between the pericranium and skull bone. So the plane is different, but the manifestation may be same. Both of them may present with swelling. Intracranial hemorrhage is uncommon, and they are associated with vacuum, which the duration of the vacuum is greater than 10 minutes or multiple application of the vacuum in that particular baby. The chances of these hemorrhage are quite increased. Okay, so to minimize this, experienced person should be there, number one, and you should not apply the vacuum more than 3 times. If third vacuum fails, you should think about some alternative option, and the best one is cesarean section. Let's move on. Okay. Now look at this picture here. All of you, please focus. What can you see here? Okay, see that, please, and few of the students can comment if they like. What can you see here?
Subgaleal bleeding.
Okay, you think this is a subgaleal bleeding? Okay, anybody else?
Laceration, sir, there is laceration due to vacuum delivery.
Okay.
It's laceration.
Marking of vacuum.
Jaundice, sir.
Sir.
Okay. Now see that so many different answers are coming. Okay, so let me clarify. That's a very good, good. You should always try. This is one of the skill you need to develop in medicine. Please remember this. Your teacher will ask the question like this: can you explain? What can you see? Exactly say what can you see there. We don't want any diagnosis at the moment. Just explain what can you see there. So let me show you that. Okay, see here. This is the circumference of that vacuum. This vacuum must have been applied for a longer duration and repeatedly, probably. So some tissue damage is already seen here. It looks like a bit of laceration actually, but okay, there is no bleeding at the moment. A slight amount of reddish appearance can be seen. So I'm not totally convinced that complete type of laceration has occurred, but this is definitely one of the complications of vacuum cup application. This can occur if the vacuum is applied for a longer duration and repeated times. Now, underneath this area, there is a high chance of hemorrhage underneath the area, and that hemorrhage can occur in below gallia aponeurotica, which is known as subgaleal hemorrhage. It can occur as a cephalhematoma, that is between the pericranium and the cranial or skull bone, and sometimes very rarely inside the cranial cavity as well. Now, with this, okay, let me enter into the probably the most important among them all. And if any question comes from here, we love to ask you about the cesarean section. So please pay attention. Let's enter into the topic, cesarean section. Now, what is the definition or the meaning? Cesarean section is a procedure in which the fetus is delivered through the incision in the maternal anterior abdominal and uterine wall. Now, why it is necessary? Okay, what are the indications? How we do it? What complication can happen? Let's talk everything in this class. But in the beginning, if they ask you the question, what is cesarean section? You can exactly answer like this. It is a type of operation or surgery in which the fetus is delivered through anterior abdominal wall of the mother. Now, how you deliver through the anterior abdominal wall? Of course, you need to cut the anterior uterine wall also, then only it is a possibility. So, through the incision in the uterine wall and anterior abdominal wall, we take the baby out. That is known as cesarean section. So, in short, okay, cesarean section means it's a combination of laparotomy and hysterotomy. Now, what is laparotomy?
Sir, it is incision in the anterior abdominal wall.
Incision of the abdominal cavity.
Exactly. Absolutely right. This is entering into the abdominal cavity or entering into the peritoneal cavity. That is called a laparotomy. Okay. And hysterotomy means, what is hysterotomy?
Sir, it is incision in the uterine wall.
Incision in the uterus.
Exactly. Incision in the uterus. Very good answer. Incision in the uterus. We are opening that uterine cavity. That is known as hysterotomy. So combination of laparotomy and hysterotomy is called cesarean section. That's a very good way of explaining it. Now, what are the risks, okay, of cesarean section? Now see here. Cesarean section, okay, should be done with some anesthesia. You cannot do cesarean section without anesthesia because you are cutting the anterior abdominal wall. You are cutting the anterior wall of the uterus. Okay, we are not concerned about the anterior wall of the uterus because it is a visceral organ, and when we cut the visceral organ, there will be no pain. You all know that. But the parietal peritoneum, when you cut, there will be pain, and all the anterior abdominal wall, these are the part of our somatic layer. It causes a lot of pain. So without anesthesia, cesarean section cannot be done. That anesthesia is of different type. The most commonly given anesthesia is spinal anesthesia. Spinal. Okay, I'm sure many of the students have seen or probably studied or maybe seen the video also. Spinal anesthesia is given by doing lumbar puncture. It's the same way by which you take the CSF out. The same type of procedure. You put the needle into the subarachnoid space. Okay, then you push the medicine. Which medicine you push there? Yes? Maybe you have studied in pharmacology. Which medicine?
Oxytocin.
No. I'm talking about the spinal anesthesia now. So it's a local anesthetic drug like exactly lidocaine. Very good. Or bupivacaine, very good. Lidocaine or bupivacaine. But remember, it has to be some type of heavy local anesthetic. So bupivacaine is very commonly used for that purpose. Okay, but you can safely answer lidocaine also. No problem. We just want you to know that those are the local anesthetic drugs which are pushed into the subarachnoid cavity. Now, those local anesthetic drugs, they will anesthetize the nerves which are coming out from the spinal cord, exactly at that site. So there will be no pain when that procedure is done. This is the most commonly given anesthesia. Sometimes the surgeon or the anesthetist want to give general anesthesia to the lady. Okay, sometimes general anesthesia is also given. But if we give general anesthesia, it is a highly risky type of procedure because if there is a delay in delivery of the baby may die because of the effect of general anesthesia. Now, what I'm saying here, the risk of cesarean section is higher than with vaginal delivery, especially with emergency cesareans performed in labor. The risk is higher. The risk can be because of anesthesia. The risk can be because of the incision which is given on the anterior abdominal wall and specifically on the anterior uterine wall. The bleeding can be excessive. Okay, so cesarean section is always considered a complicated type of procedure than the normal vaginal delivery. Okay, so please, this is a take-home messages for you. Never choose cesarean section as a safer option than vaginal delivery. Vaginal delivery is always more safer than cesarean section. Maternal mortality is largely anesthetic related with overall mortality rate of 25 per 100,000. See this. This is a important data to remember. So there is a chance of maternal mortality during cesarean section. But having said that, okay, I'm not scaring you from this fact. Having said that, if an experienced person is doing it, it is absolutely safe type of procedure. There is a chance, but which procedure doesn't have any chance of complication, isn't it? There is not a single procedure which doesn't have any chance of complication. Okay, so we should not back ourselves up from doing this. Now, what are the risks of cesarean section? So after doing this, let's go for the indication. Okay, now, look at the risk. Hemorrhage. Blood loss is twice that of vaginal delivery with mean loss of 1000 ml. So there will be a lot of blood loss during cesarean section, but the lady can handle this much of blood loss. Okay, we don't need to transfuse the blood if around 1 liter of the blood is lost there, because during pregnancy usually what happens regarding the blood volume during pregnancy? What happens?
It will increase, sir.
It's increase, sir.
Due to the
Plasma level.
Exactly, the plasma volume is increased, plasma volume is increased significantly, so the lady can tolerate it. Okay, that's my point. But if it is excessive, we need to transfuse blood later on. Second important is infection. The sites of infection include endometrium, abdominal wall wound, pelvis, urinary tract, or even the lungs. So prophylactic antibiotic can decrease the chance of infectious morbidity. But many of the obstetrician, they don't want to give prophylactic antibiotic if a procedure is done under aseptic precaution. Okay, but some of them may want to give 1 or 2 shots of the antibiotic before the surgery is done. It's up to them. The third important is a visceral injury. The surrounding structure can be injured, like urinary, okay, bladder, the bowel, and the ureter. They can be injured. But let me clarify again, if the experienced person is doing cesarean section, this chance of injury is almost nil. Okay, almost nil. And one more point, during the first time, okay, for example, in primipara, if cesarean section is done for the first time in that lady, the chance of visceral injury is 0, almost 0 by experienced person. But if a repeated, cesarean section was already done, for example, this is the third time now, because of the prior incision, there is some, what happens if there is prior surgery done inside the abdomen? What is the complication of that? Anybody?
Fiber and scar formation.
Scar formation.
Exactly, you're right. Okay, there is a chance of scar formation, and we use the different term there, we use the term adhesion for that, adhesion. So there is different adhesion occurring inside the abdomen, like bowel may be attached on the entire abdominal wall, or bowel may be attached on the, the scar which is there in the uterine wall, something like that. So chance of complication will be more, okay, in case of repeated cesarean section. Another one is thrombosis. Deep venous thrombosis is increased in the pelvic and lower extremity vein after cesarean section. If the lady, is immobile for a long time, then this type of complications are increasingly occurring. Let's move on. Now, what are the types of uterine incision in case of cesarean section? What incision we are going to give? But before that, okay, let me talk about what are the abdominal incision first, okay? Because we have to give the abdominal incision in the beginning, then only you can enter into the uterus. So what are those abdominal incision? So let me clarify this right now. Now see there, the abdominal incision. Now you can guess it, okay? You can use your common sense here. What type of abdominal incision you give in laparotomy? What is that abdominal incision in laparotomy you give? Yes? Anybody? Okay, probably we have not talked about that, okay? It will be taught in abdominal surgery. Don't worry. After finishing the basic things, you will enter into the abdominal surgery and it will be taught there. This is known as midline incision. Midline, okay? Midline, exactly. Or paramedian. Midline or paramedian incision. Either exactly in the midline or a bit, on the side, paramedian incision. This is one. Okay, this is one. But even more important than that incision in case of cesarean section is called fan steel incision. It is a little bit difficult spelling for you. Okay, so you need to remember this. Fan steel incision. This fan steel incision is, okay, it is the transverse type of incision just above the symphysis pubis joint. So it is given way below, okay, a bit of horizontally, or you can say transversely across the midline, just above the symphysis pubis. This is known as fan steel incision. This incision is very, very commonly done these days. Nobody is giving that midline or paramedian incision for the sake of cesarean section. So you can confidently answer fan steel incision is given and the entire abdominal wall for cesarean section. If they ask you what is that, you can simply say this is a horizontal type of incision, a slightly curved incision, okay, just above the symphysis pubis. Now let's talk about uterine incision now. And one more thing, where is this midline? Midline is a big area, isn't it, in the entire abdominal wall? So this midline here means below the umbilicus, okay, below the umbilicus and above the symphysis pubis. That particular part of the midline is incised. The surgeon doesn't need to go higher than umbilicus. So in the uterus, okay, there are again two types of incision which can be given, but the much more common and the important one is low segment transverse incision. That's why in different textbook it is known as lower segment caesarean section, LSCS, lower segment caesarean section, very commonly used term. Why? Because they give the incision in the lower segment of the uterus. Now see that this incision is made in the non-contractile portion of the uterus, which is known as lower segment, and it is one most commonly used rather than other. The bladder must be dissected off the lower uterine segment first before you cut the anterior wall of the uterus. The bladder is slightly dissected and it should be pushed downwards. Otherwise, there is a chance of damage to the urinary bladder, and that's a disaster if that happens. But experienced surgeon will never do that. It has a low chance of uterine rupture in subsequent labor, only 0.5% chance of rupture. That is almost, non-existent type of rupture, isn't it? So it is quite a safe type of incision. Advantages of this are trial of labor in a subsequent pregnancy is safe. The risk of bleeding and adhesion is less. So it has a, different types of advantage here. If we have delivered the baby by cesarean section during this time or during this pregnancy, then later on she may be pregnant again. So during that time also we can safely go for cesarean section, or even the vaginal delivery can be done. Okay, that is safe after giving lower segment transverse incision. Risk of bleeding and adhesions are also less. Disadvantages are the fetus must be in longitudinal lie for this type of delivery, okay, and the lower segment must be developed. But these we can diagnose before, we can palpate before we do the cesarean section. What is the lie of the baby? And usually the lie is longitudinal. Transverse lie is very rare. Okay? So make sure the baby is in longitudinal lie before giving lower segment cesarean section. Now look at this, a picture, then you will be quite clear what I'm talking about here. This is known as, okay, low transverse incision or lower segment caesarean section. This is a uterus, okay, there's the uterus. This is, retracting the urinary bladder. See, urinary bladder is right here, okay, so we need to push it downwards with the help of retractor. And this is the lower uterine segment, and they have given incision here. So this is lower segment caesarean section. Whereas this is incising right there on the body of the uterus, or in other words, the upper uterine segment, is incise, and this is known as classical incision. There are lots of complication associated with classical incision. So these days it is almost not done. Remember this, it is almost not done. In few exceptional cases only they go for it. Now, please mute yourself. Now, what is this classical incision? So let's talk a little bit about it. Okay, classical incision. See here. This incision is made in the contractile fundus of the uterus and of course the body of the uterus also, and is less commonly performed. Technically, it is easy to perform and no bladder dissection is needed because it is way higher. Urinary bladder doesn't reach there. So technically speaking, it is easy to perform, but later on the risks are too many, so it is not usually employed. See here, the risk of uterine rupture both before the labor as well as in a subsequent labor is significant. It is significant. The risk of uterine rupture is 5%, whereas in lower segment cesarean section it is just 0.5%. So there is a massive difference. And repeat cesarean should be scheduled before the labor onset. The lady cannot go for vaginal delivery after the classical type of cesarean section. She has to be planned for another cesarean section again in the future. But after lower segment cesarean section, we can give a trial of vaginal delivery next time. This is another important difference. Advantages are any fetuses regardless of the uterine intrauterine orientation can be delivered. Even the transverse lie can be delivered through the classical incision. Lower segment varicosities or myomas can be bypassed, like transverse lie, placenta previa if you are there, then also we can go through this type of delivery. So these are the advantages. But let me ask you one question. How common are these type of things? They are not common, only in exceptional cases these occur in the pregnancy. That's why it is not the common way of incision there. Regarding the disadvantages, the trial of labor in a subsequent pregnancy is unsafe. I already told you, once you deliver the baby by classical cesarean section, next time also cesarean section has to be done. We cannot give a trial of vaginal delivery. The risk of bleeding and the addition is higher, much more higher than lower segment cesarean section, and the chance of rupture is also high. Now, before we move further, these are the major differences between lower segment cesarean section and the classical cesarean section. So classical cesarean section means the incision is given in the contractile part of the uterus, means upper uterine segment, whereas lower transverse incision is given in lower segment cesarean section. The upper is considered more complicated than the lower one. That's why lower is very, very commonly done these days than the upper. Talking about the different types of incisions, now let's enter into the very important part, that is indication. Indication means in which situation the obstetrician want to go for cesarean section. That is called indication. The one of the most common and important indication is known as cephalopelvic disproportion. Just analyze the term. Cephalo is head. Pelvic is a pelvic cavity of the mother. If head is too big or bigger than the pelvic cavity, or if pelvic cavity is contracted or smaller in size, the baby cannot be delivered through the vaginal route. So this has to be one of the most important, indication for cesarean section. So this is the most common indication. This term literally means the pelvis is too small for the fetal head. In actual practice, it commonly indicates the failure of the adequate progress in labor, which may be related to the dysfunctional labor or suboptimal fetal head orientation. This is how we identify there is a cephalopelvic disproportion. There is no engagement of the fetal head, number one. Number two, there is a good contraction of the uterus, but fetus is not coming downward, and the occipital anterior position is not going to develop. Means there is no rotation of the fetal head. All these are important indicator of CPD. And before the delivery, this has to be diagnosed, by diagonal conjugate measurement. That is the most important way. Another common indication is fetal malpresentation, like a breech presentation. These days, breech presentation will be delivered by cesarean section. Nobody want to take any chances there, okay? So it has to be delivered by a cesarean section, though we can give a trial of vaginal delivery even in the breech. But one of the dangers is there is after coming head which may stuck in breech delivery, and because of that sometimes the baby may die. So to avoid that situation, better to go for cesarean section. Let's move on. Now see there, the other indications: non-reassuring electronic fetal monitor strip. In other words, fetal distress. These days, this fetal distress is one of the very, very common indication for cesarean section. So what does that mean? By any means, okay, if you detect the fetal heart rate is either more than 180 or less than 100, then quick cesarean section has to be done, or other method of delivery should be employed to take the baby quickly out. Otherwise, the baby may die there. But sometimes this may be used as a commercialization also. Now, why? Let me explain this for you. Okay, the public or the layman, they don't know what is fetal distress, isn't it? They don't even cross-check. Whatever the obstetrician tells them, they will believe it. And if the obstetrician tells, yes, your baby is having a bit of problem regarding the oxygenation or something like that, and it has to be quickly taken out, the parents say, of course, please go ahead. I want my baby, intact. This is another, thing which is occurring these days. Okay, I'm not criticizing anyone here, but it is commonly happening in few of the centers. Another indication, okay, for cesarean section would be previous cesarean section. Now, once a cesarean section is done in the past, it is not absolutely necessary that second time also a cesarean section should be done, but it is usually done. Nobody wants to give trial for vaginal delivery after that. But remember, just now what I told you, there are two types of incision on the anterior wall of the uterus. One is lower segment cesarean section, another is a classical one. Once you deliver the baby by classical cesarean section, next time cesarean section must be done. But if you have delivered the baby by lower segment cesarean section, then you can give a trial of vaginal delivery next time. It is all about the choices of the obstetrician and the family, of course. If there are multiple fetus, okay, that can be indication for cesarean section. Placental abruption, abruptio placentae, okay, this is one of the cause of antepartum hemorrhage. Cesarean section is a common modality of delivery. Placenta previa, especially grade 3 and 4 type of placenta previa, cesarean section has to be done. Vasa previa, cesarean section is done. And whenever the risk to the mother or the fetus from vaginal delivery exceeds that from operative intervention, a cesarean section should be undertaken. One of the good example I want to give here is big baby. If the baby is more than 4 kg, okay, which is already diagnosed by ultrasound, don't give a trial of vaginal delivery there. There's too much risky. Okay, so baby should be taken by cesarean section. Now, this is the other way of answering this question. If your teacher asks, okay, what are the indications of cesarean section? Means these are the contraindication to vaginal delivery or the normal labor. This is a good way to remember. Placenta previa, we don't go for normal labor or non-vaginal delivery, isn't it? It's too risky. So let's go for cesarean section. Vasa previa, same thing. Previous classical cesarean section, already talked about. Cesarean section has to be done again. previous myomectomy with entrance into the uterine cavity, there is a high chance of adhesion, scar formation, all those things. So better to do cesarean section. If we go for vaginal delivery, there is high chance of rupture of the uterus. Previous uterine reconstruction, high chance of rupture if we try for vaginal. Malpresentation of the fetus, better to go for cesarean section because there is obstructed liver. Active genital herpes infection. Now, which herpes virus is responsible for genital herpes?
The herpes simplex virus.
Yes, which?
Herpes.
There are two
Herpes.
types.
Simplex
One or
type 1,
two?
sir.
Type 1
One.
herpes.
Type
Okay, so you are a bit confused here. There are two types of herpes simplex virus, HSV1 and HSV2. So let me clarify quickly here. HSV1 and HSV2. See here. Okay, and HSV1 usually leads orofacial infection, infection around the face and the oral cavity or in the lips. HSV1 will do that, and HSV2 is important for genital infection. Never forget this. Having said that, okay, you can add one more sentence there. These days, okay, it has been proven that HSV1 can also lead to genital infection and HSV2 can lead to oral infection, but that is not very common in comparison to the first statement which I told you. HSV2 is a very, very prevalent or common pathogen for genital infection. Now, if mother is having active genital herpes infection, if we try for vaginal delivery, remember there is a contamination. There is a direct contamination to the baby, and this baby may be delivered with active viral infection, and the baby may develop septicemia. This baby may develop encephalitis also. So to avoid that situation, better to deliver by cesarean section. Another one, previous cesarean section and patient declines the trial of labor. So these days, isn't it? People are, aware of the situation, okay? Because of the, internet, the facility of the internet, they can also check what is best for them. And sometimes they are afraid of the trial of vaginal delivery because of a lot of pain. Pain of that labor. They want to avoid that. So they themselves, request the doctor, I want cesarean section on me. And that is one of the common indication these days. But let me clarify you again. This is not according to the patient wish, okay? If you are working in a very busy hospital, there are lots and lots of cases there. You have to decide on your own. If there is a real indication, just go for it. Otherwise, the lady who really needs cesarean section will be declined, and the lady who doesn't need cesarean section will be preferred. That should not happen. In a private hospital, they want to earn more money anyhow. They are doing cesarean section just according to the patient wish. So let's move on. Now, other types of conditions where cesarean section is done is dystocia and failed induction of the labor. Dystocia is abnormal labor. Eutocia is normal labor. We all know the term now. And when failed induction of labor is there, you have to go for cesarean section. And these are the situations where this happen. See there, again CPD or cephalopelvic disproportion, failure to descend or arrest of the descent or dilation of the cervix. There's no other way, you go for cesarean. Failed forceps or vacuum delivery, go for cesarean. Certain fetal malformation that may obstruct labor, like large hydrocephalus, sacrococcygeal tumor, okay, a big cyst which is present in the neck, isn't it? So all these are delivered by cesarean section because there is obstruction of the labor. Quite easy to understand. Another is the emergent condition that warrant immediate delivery. Okay, that warrant immediate delivery means we cannot wait a bit longer now. There may be danger to the mother or the baby health. So these are the situations. Abruptio placentae with evidence of maternal or fetal compromise. The fetal distress is already developed. Quickly take the baby out. Umbilical cord prolapse. Quickly take the baby out by cesarean section. Non-reassuring antepartum or intrapartum fetal testing. Fetal distress again. Intrapartum fetal acidemia. That means, see this, scalp pH of less than 7.2. Now, you all know what is the normal pH? What is the normal pH value? Anybody?
7.35 to 7.4.
7.4.
Now, see there, good. So, good answer, 7.35 to 7.45. This is the range, 7.35 to 7.45. And absolutely average, okay, is the 7.4. You can easily answer this. 7.4 is the pH. Now see this, 7.2 is a very, very low pH. That means this is acidic, okay? This is acidic pH, also known as fetal acidemia. And this fetal acidemia is developed because of fetal hypoxia. It's already a bit late. So, but still there is a hope, isn't it? So quickly deliver the baby by cesarean section and go for the fetal resuscitation. Uterine rupture, there is no other way. Deliver the baby by cesarean section, and persistent bradycardia is another indication, just to save the baby in time. Now, let's talk about some more information regarding cesarean section. What is the chance of vaginal birth after cesarean? Okay, a lot of information you already know, but still, let me talk a bit more about it. Successful vaginal delivery rate is 70% in carefully selected patient. So what does that mean? These days, many cesarean sections are conducted by lower segment cesarean section, LSCS, and we can give a trial of vaginal delivery in the next time. Okay. The dictum, once a cesarean section, always a cesarean section, is not true. It is not true. And sometimes it may be used for a commercial purpose. Many of the private hospitals are actually doing that. Up to 70% of the women with the previous cesarean section can achieve a vaginal delivery. But remember, there are certain criteria. One of the important criteria is the previous cesarean section has to be done by lower segment cesarean section and not the classical one. Criteria for trial of the labor include patient's consent. Without the patient's consent, you cannot give a trial of labor. You cannot force your plan on that lady. So informed consent has to be taken, okay? If patient wishes for cesarean section, we need to isn't it, go for that. But one important point I told you before, it depends on your hospital situation also. If you are working in that very, very busy hospital, if you think this patient can go for a trial of labor, you can go for it. But if patient do not want, you can safely refer that patient to somewhere else. Another criteria for the trial of labor is non-repetitive cesarean indication, like breech and placenta previa. Okay, breech and placenta previa. So you don't go for trial of labor there. This may be too risky, but you can give a try. Like just think about it. Placenta previa can be of different type, grade 1, grade 2. We can go for the trial of labor. Even in breech delivery, she can go for a trial of labor, but they are too risky. So it is again the doctor's decision here. Previous low segment transverse uterine incision and clinically adequate pelvis are some other criteria for the trial of labor. The surgeon can go, for the trial of labor, and if it fails, then cesarean section is always there. Now we are coming towards the end of this topic. What are the complications of cesarean section? can easily list few of them. One is endomyometritis. What is the meaning? Endomyometritis means what?
Endometrial inflammation, sir.
Exactly. Endometrial and myometrial inflammation or infection. And
It can lead to iatrogenic perforation.
Exactly. It is because of the iatrogenic, definitely, because uterus is a sterile organ. Okay, so that there is no prior infection there. Somehow, if the surgery was not properly done, if the sterilization was not maintained, then this complication can occur. So around 5 to 50% of the time it can happen, and usually there are multiple microorganisms involved, like aerobic streptococci, anaerobic gram-positive cocci, and aerobic and anaerobic gram-negative bacilli as well. Okay, this is known as polymicrobial. To reduce this, there can be use of prophylactic antibiotic, and if they use, the chance is less than 2%. It depends on the surgeon. If they believe their operation theater is absolutely sterilized, everything is properly sterilized under aseptic precaution, they don't need to give prophylactic antibiotic. But if there is a slight doubt, always better to give. Second complication is urinary tract infection. During cesarean delivery, catheterization is the must. Okay, catheterization has to be kept there, and because of that catheter, a urinary tract infection can occur. Third is the wound infection, and look at the percentage of chances here. You don't need to remember this percent, okay? Just remember it can occur. 2.5% to 16% of the lady can develop wound infection, and this is a disaster. That wound is quite a big wound in the anterior abdominal wall. If this is infected, how we are going to treat this wound if it is infected after cesarean section? We have done this in surgery. What should be done now?
We don't suture this.
We should keep it open and we should sterilize it.
Yes, minimizing the contamination by sterilization process and keeping it open.
Very good. So students are answering in absolutely correct way. Number one, remove the sutures. Remove the suture. Number two, keep the wound open. Okay, use antibiotics. Okay, clean that wound. Allow that wound to heal, and then only resuture it. This is the way. Okay, do not try to treat it with sutures there. This is not going to heal in time. Another complication is a thromboembolic disorder like DVT, deep vein thrombosis. Pregnancy is a thrombogenic state. Everybody know that. On top of it, there is a surgery just happened. So that if that lady doesn't mobilize herself, there is a chance of deep vein thrombosis. Another complication is a uterine rupture in future pregnancy. Okay, uterine rupture in future pregnancy, because there is a scar in the uterus now, and the risk of rupture of a previous cesarean scar varies with the location of the incision. Now see here, if there is a low transverse scar, the rupture chance is less than 1%. If there is a low vertical scar, which is not commonly given, but if the surgeon has given it, 0.5 to 6.5%. But if there is a classical scar given, it is as high as 10%. So that is the take-home messages from the class. Because of the single most important risk, the classical incision was not given while doing cesarean section. And if they ask you what is that classical incision, you say it is given in the upper uterine segment. In the contractile part of the uterus, the incision was given.